Welcome to MedMythBusters RSV. I'm Rachel Deere with DKB Med. I'd like to introduce our esteemed faculty, Dr. Paul Auwaerter, Clinical Director in the Division of Infectious Diseases and Sherilyn and Ken Fisher Professor of Medicine at the Fisher Center for Environmental Infectious Diseases at the Johns Hopkins University School of Medicine. Before I turn it over to Dr. Auwaerter, a few housekeeping items. Here are Dr. Auwaerter's disclosures. This program is brought to you through the generous support of DKB Med and the Institute for Johns Hopkins Nursing. Our learning objective is describe the recommendations for and safety of vaccines for RSV. And now, Dr. Auwaerter.
Hello, thank you for joining. I am Dr. Paul Auwaerter, and welcome to MedMythBusters. Today, we'll be talking about respiratory viral illnesses with a focus on respiratory syncytial virus, which almost everyone in the medical profession goes by its shorthand, RSV. RSV is one of the big three. Now, obviously, there's lots of other viruses capable of causing upper as well as lower respiratory tract illness. But amongst the big three, we have influenza and also, of course, SARS-CoV-2 or COVID, which has joined us since 2020, with our RSV bringing up usually the rear. Now, we really don't know how many COVID cases are ongoing since we're no longer tracking that very well. And the other estimates for seasonal influenza and RSV also are estimates, but clearly influenza often is in the lead nowadays, and we'll talk about that shortly. But there's certainly a fair number of illnesses due to RSV, as you can see here, typically in a season from a couple years ago, just after the heat of the pandemic, was 4 million cases with a little over 900,000 ED visits, over 100,000 hospitalizations, and also a considerable number of fatalities. So these are among the important viruses to consider for our patients. So let's address the first myth. RSV and influenza appear to have sudden onset. This is a falsehood. So if we look at the spectrum of typical issues, the big three and a cold, the spectrum of illness in terms of who it affects is almost the same in terms of who we worry about most. Young children and also older adults, often with health problems. The only thing that's a bit different is COVID generally doesn't affect children to the same degree and severity that RSV and influenza does. But generally, the symptoms you certainly can't be sure of distinguishing on a clinical basis. There's a lot of overlap with cough, sneezing, feeling achy, and so on. But here's the thing that I would say sometimes can be very helpful in terms of heightening the suspicion for one over the other. Influenza can come on rather abruptly in a matter of hours. I've had this myself where I remember in clinic, I felt fine in the morning clinic. By the afternoon, in the space of 2 or 3 hours, I was very certain I should withdraw myself from the office because I felt very achy. I began to have chills, a headache, and just felt really awful. On the other hand, COVID and RSV has rather gradual onset. And I think one of the other things that RSV generally doesn't do quite as much is have the sort of severe flu-like symptoms that you might get with either SARS-CoV-2 or influenza. But regardless, you really can't be absolutely sure. And certainly the Centers for Disease Control now and many others espouse that testing is the way to really nail it in this situation to help advise our patients on whether there might be a therapeutic or just symptomatic and supportive care. So here's another potential fact. RSV appears throughout the year at a similar rate. This is a myth. Emergency room visits generally have increased in the winter or fall months for RSV. You can see here just in last year through really this current month that we're recording this in February, the uptick, especially in influenza, which generally does peak and has more sort of contagious features and spread during the colder winter months, but also tracking our COVID, which is year round, but RSV generally occurs in the fall and winter. So looking at this by another way of just who's testing positive in a national reporting service, you can see influenza, this particular respiratory season, has really taken off since the December holidays, and in fact is quite widespread in many parts of our country. And by comparison, COVID, interestingly, has sort of taken a back seat and is in third place, with RSV coming in place, as it were, in this horse race, but with a substantial number of cases beginning in early to middle fall, and through the winter season. Now, COVID certainly impacted how RSV came about, with a very severe run of RSV immediately post pandemic. But you can see with the green curves here, the sort of traditional time frame where we began to see an uptick in RSV, often with the onset of school in September and October. It's sort of peaking classically in late November through January, and then decreasing. And this probably is how this is going to behave in this season as well. Here's another potential myth. Antibiotics are required for all acute respiratory infections. This is clearly false, and I think many of you realize this is an easy one to bust. But the reality is the following. Antibiotics are commonly given to people who are presenting with what is probably just a pedestrian upper respiratory tract infection. And we see this all the time, right? People are suffering from a cough. They might be coughing up colored green or yellow phlegm, and they feel an antibiotic will help them feel better faster, get them back to school or to work or so on. But the reality is that's really not worthy of using precious antibiotics, which can certainly foster antimicrobial resistance due to overuse. And a number of studies have addressed this. This is just one on this slide that was quite large, whereby over 40% of people got an antibiotic when clearly over 85% or so of people had just a bronchitis or upper respiratory tract illness. And basically, especially as people got older, antibiotics were prescribed, probably because of the fear of pneumonia. But the reality is, when you have an upper respiratory tract infection that's viral, the antibiotics don't do anything. The risk of pneumonia is at most 1 in 800 or so in terms of progressing, and giving antibiotics just in case. There's squarely no information that this helps prevent acquisition of pneumonias developing as a consequence. So basically, this study found that about a third of people, even who had influenza, yet still got an antibacterial. So I think there's a lot of issues to unpack in studies like this. First, you can nowadays do antigen testing at home or in the office to diagnose influenza or COVID. And both of those are important because I think antivirals can be given to those patients at high risk. RSV, we don't have a lot of rapid testing available except in emergency departments and so on. And that is a virus that only gets supportive care rather than an antiviral. But the clear blanket statement here that is true is that Antibiotics are often overprescribed. They're given unnecessarily. They don't help our patients, and there is no doubt some public health aspects where they could prove harmful. Now, the good news might be in addressing this myth. RSV vaccine is only for the very young or very old people. This is a falsehood. RSV, much like influenza or COVID, is an issue for adults who are experiencing comorbidities in a wide range of situations, much like COVID or influenza. So I don't think you really have to memorize another set of risk conditions. But people that have cardiopulmonary problems, diabetes, liver disease, kidney disease, might reside in nursing facilities or have other significant chronic health problems, all are at risk of having RSV, which is often just a pedestrian viral illness for someone that's healthy as an adult and can really place them in terms of going into the hospital, just like influenza or COVID. So in order to address this, a number of vaccines have been developed, and there are actually 3 that are available to help protect people. Now, originally, these were espoused for people 60 and older, and that's how they were approved by the Food and Drug Administration, but we'll get to the ACIP recommendations shortly. So all 3 address something called the pre-fusion protein of RSV and have antibodies that will help prevent with acquiring infection. So there are some subtle distinguishing features here. They're all approved for people over 60. However, the one that's on the top bullet, which is the Pfizer vaccine, is also approved for people 18 to 59 who are at risk for severe RSV or pregnancy in the last weeks of gestation for prevention of RSV disease in the infant because of the transmission of maternal protective antibodies. There's also a GSK vaccine that's also approved for people over 50 with health problems that we've just reviewed. And then Moderna has made an mRNA vaccine very similar to the SARS-CoV-2 technology, still using an antigen target, which is the pre-fusion protein. It was approved last year. Now, the Centers for Disease Control and the Advisory Committee on Immunization Practices do not say one should be used over the other, as long as it's being used for the right indications here. So there's no clear preference, but you should just use whatever might be available and offer protection for someone. Each of these are just a single vaccine, and the vaccine efficacy from studies is quite good. In the first year for upwards of 88% in terms of prevention of infection, with only anticipated local reactions where people are immunized. So in terms of availability of pathways for offering RSV protection against illness and acquisition of infection, if we start off at the youngest ages, those that might be at risk, in fact, get monoclonal antibodies. And so those products are there because people that are that young, infants especially, won't respond well to immunizations against RSV. So they rely on a monoclonal antibody infusion. However, if you look at the adult groups here, pregnant women can get the vaccine just before or during the RSV season if their last part of their 3rd trimester is coincident, as you can see here. And then same for adults who have comorbidities, would be the same Pfizer vaccine. But otherwise, for people 60 and older, the recommendations are if you're 75 and older to get the RSV vaccine, but if you're between 60 and 74, only those with risk factors. So this is just a one-time only vaccine. We know it provides coverage for at least 2 years and appears to be likely doing fine for at least 3 years, but of course they're new, and so time will tell whether a booster is needed, but for the moment, none would be. And in terms of timing, the right time to get it is just the same time as you might begin thinking about influenza immunization, so August through September, before the October and November RSV months are in their prime. So here's another potential myth. RSV vaccine has so many safety concerns, it's not worth the risk. This is mostly false. In terms of RSV vaccine safety, when studies were submitted to the Food and Drug Administration from their pivotal studies, there were really no severe problems seen other than the local reactions. And it was only when the vaccine was uptaken by the larger populations that the vaccine databases that track potential side effects found that rates of Guillain-Barré syndrome might be a little higher than expected for background rates. And what it seems to be is if you're looking at adults 60 and older, there might be 10 excess cases of Guillain-Barré per million adults. So when this came about, how this was revised is instead of espousing adults 60 and older universally to get RSV vaccine like the FDA approval, it was shifted. So the decision was made to target adults 75 and older because those seem to be the adults most at risk for severe illness and landing in the hospital. So the FDA did add a warning based on a Medicare claims data for adults over 65 about Guillain-Barré. So it is certainly something to advise patients, but what I've done is talk to patients about this and say the risks are fairly low, and simply your risk of getting RSV is higher to put you in the hospital or even potentially dying of severe infection. So therefore, the benefits of the RSV vaccine in these populations, so 75 and older, or those 60 and 75 with health problems outweigh the limited but potential risks of Guillain-Barré syndrome. And if you look at Guillain-Barré syndrome after RSV, it's slightly lower compared to Guillain-Barré syndrome following flu vaccination. So I think this may also provide some reassurance for your patients who are getting their flu vaccine on a regular basis. So vaccine safety was studied in pregnant women. And importantly, what was determined is that RSV infection can certainly induce preterm birth. So therefore, targeting especially the last few weeks of gestation might be a twofer in that if RSV vaccine is used, women are protected from having preterm birth, but also maternal antibodies can help prevent RSV infection in infants, especially those 6 months and younger who are at highest risk. In terms of safety, as you can see here, incidence of preterm births were exactly as expected during this age range, falling squarely in the middle. So just from a safety perspective, it didn't look like the vaccine actually induced risk, which is another way of looking at this. So here are 3 takeaways that I hope might help your patients down the road in terms of RSV and its potential health consequences. First, based on looking at the rare but potential risk of Guillain-Barré, there was a shift such that now, if you're relatively healthy, instead of 60, 75 is the new age. And if you're older than that, where RSV appears to be beneficial for protecting against severe RSV disease, or if you're between 60 and 74, if you have health risks that might place you at severe disease. For the time being, The second point would be that there's no boosters needed. I get this question all the time. There's at least 2 solid years of protection and probably 3 as well. And we'll get more data on this over time and address whether booster at all is ever needed. Lastly, the vaccine is generally well tolerated. I've certainly found that in my practice. Patients have not really had much in the way of complaints due to the injection. And there's a small risk of Guillain-Barré with safety warnings added to the 2 protein products, but not the mRNA vaccine, probably because it hasn't yet been used widely enough to see whether there's a true increased incidence or not. So stay tuned for that. Thanks so much for taking some time to listen about seasonal respiratory viruses with a focus on RSV. Hope these myths, as we busted them, can help your patients.
Thank you to Dr. Auwaerter for busting those myths about RSV. Thank you for watching. If you'd like to claim ANCC credit, please click the Claim Credit button to take the evaluation. Your thoughts and comments are important and help us develop additional education for MedMythBusters. I'm Rachel Deere with DKB Med.